The St. Gallen Congress, which is now held in Vienna, is dedicated to adjuvant treatment of breast cancer. So all areas around surgery, radiation therapy, and medical therapy in the early setting of breast cancer are going to be discussed, basically in educational lectures. The highlight of the Congress is always on the Saturday morning, when we have a panel that, after months of preparation, going back and forth with questions, is presented the questions again and has to vote. And they can either vote in favor, against, or abstain about a particular question. There are many areas in oncology where we don't have sufficient evidence to have 100% concordance. And these are the areas so-called controversy. And this is what is going to be discussed. Areas of controversy in surgery, for example, which I believe are quite fascinating, are the continuous discussion about what are adequate margins around the tumor. Is it that there is no tumor cells in the ink? Is it that you have 1 millimeter, 3 millimeters? It's going to be fascinating. From the radiation oncology perspective, they are going to have lots of discussions, and one of the discussions is, of course, about the acceptability today of radiation given during the operation without need for further radiation, i.e. in one shot during the operation you do what is usually done in 4 to 6 weeks, sometimes now in accelerated programs in 3 weeks. And in the medical oncology side, I think that there are so many questions that are still open. And among them, I think an important one is, what is the level of acceptability to the panel of a recently accepted neoadjuvant treatment with a dual combination of 2 anti-HER2 agents along with chemotherapy? Is this really now an alternative, or is this something that needs to be further explored because it was accepted on the basis of relatively limited clinical trials? And then there are some areas, of course, I have my biased view of what is interesting, and my biased view is that there's going to be discussion again about the position of bisphosphonates in the adjuvant setting, which I personally believe are extremely important. All the data point to the fact that they give an advantage which is, in terms of survival in postmenopausal patients, very similar to what you can get when you go from tamoxifen to aromatase inhibitors. And then finally, my area of interest is also in geriatric oncology. So elderly patients, questions are, is there an age limit at which you apply adjuvant chemotherapy? Is this limit related more to the characteristics of the tumor and of the patient? And of course, that's, in my eyes, the correct answer. I hope they will answer this way. And the other point about the older patients is when is it possible to not give radiation therapy in patients operated conservatively, because they have very low risk of relapse and much higher risk of dying from something else. So these are some areas of debate that's going to be on Saturday. Well, then, besides the main program at the St. Gallen Vienna meeting, there are also presentations of data from many groups, and I've been working with colleagues on the development of a new antiemetic agent, which has been recently recognized by the FDA in the United States and is under scrutiny of the EMA in Europe. It's a combination of an NK receptor antagonist called netupitant along with 5-HT receptor antagonist called palonosetron, so NEPA. And the commercial name in the US and probably in Europe is Akinzeo. The compound has shown clearly that, as expected, when you combine these two types of agents along with corticosteroids, it is superior to 5-HT receptor antagonists and corticosteroids. And the advantage is that with a single capsule, the patient has 2 active compounds. It is an oral combination. We believe in Europe it's going to be something that is going to be quite well received. In the United States, oral treatments are always an issue, so maybe they will continue to use intravenous treatments. In the perspective of the future, if you look at the crystal ball, there are many things that are changing extremely quickly in the treatment of breast cancer. Let's say the first one, and which is extremely important, is that more and more centers recognize that it's not only important to give the best possible treatment to the patient, it's also important to listen to the patient and take into account all the problems that the patient faces when she has breast cancer, and the few males that have breast cancer. Then biology is being understood better and better. And this really should define our adjuvant treatment. It's not about gross identification of whether the patient has positive lymph nodes or not, or size of the tumor as it used to be 20 years ago. It's biology as it is today. We have several tools that allow a much better molecular definition of the tumors. And along that, we have the development in areas that we thought could not have a development, like hormone receptor positive HER2 negative tumors. We realized that there's much more than what we have. There are many interesting agents, first developed now in the setting of metastatic disease, which will soon be studied in the adjuvant setting, which are probably going to allow even better treatment for the patients, avoiding chemotherapies and some of the side effects, even though we must say that some of these agents that are so-called targeted also have their own side effect profiles.